And hello once again, pharmacology students. Today I would like for us to talk about ventricular tachycardias. Now a little bit of terminology. If you have bradycardia, then your heart rate is going to be lower than 60 beats per minute. So it'll be lower than 60 beats per minute. If you have tachycardia, your heart rate is higher than 100 beats per minute. So a normal heart rate is typically between 60 to 100 beats per minute. And if you are below that, you have bradycardia. If you are above that, you have tachycardia. Now let's remember that any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity is called an arrhythmia. So any disturbance in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity is by definition an arrhythmia. An arrhythmia. Now let's throw some things out here because it's possible for you to have a physiologic tachycardia. So physiologic tachycardia occurs, of course, during exercise. During exercise, your heart rate will increase, and it will increase to rates that are greater than 100 beats per minute. Of course, it depends upon the intensity of your exercise, but that is physiologic tachycardia. That's an increase in the heart rate in response to the demands of your body. No big worry there. Then you can also have physiologic bradycardia. And this is the case with, for example, aerobic athletes. So your aerobic athletes, their heart rate might be between 40 to 60 beats per minute. That's due to increased activity of the vagus nerve. And that is completely normal. Some drugs can also cause bradycardia. So for example, your beta blockers, they can cause bradycardia, so can calcium channel blockers. In particular, two calcium channel blockers, there's two groups of calcium channel blockers, the so-called dihydropyridine calcium channel blockers that are used mainly to control blood pressure. The two calcium channel blockers that will cause bradycardia are verapamil and I completely misspelled that. Verapamil and then diltiazem. These are the two calcium channel blockers, non-dihydropyridines, that can cause bradycardia. Then there are also pathologic causes of tachycardia and bradycardia. I'd like to look today at the examples of ventricular tachycardia. So let's take, for example, let's have a gentleman, let's call him, Clint. So Clint is a 21-year-old college student. And he is brought to the emergency department. And he has a very fast heart rate. In fact, it's about 170 beats per minute. So that is definitely tachycardia. Now, Clint has a history of depression. So he has so-called mental depressive disorder. His mental depressive disorder is such that it needs to be treated with medication, and he's being treated with a tricyclic antidepressant. And it is amitriptyline. I think I misspelled that. That's an I. Amitriptyline. And his EKG looks like this. So I think we'd agree that does not look normal. So again, to review very quickly what a normal EKG should look like, you should have a P wave followed by a QRS complex followed by a T wave. The P wave indicates the atrial depolarization, QRS indicates ventricular depolarization, and the T wave indicates ventricular repolarization. And I think you can agree if you look at this and then you look at this, this does not look anything like this. So that's his EKG, very, very abnormal. So what are the different types of ventricular tachycardias? Why, first of all, do we want to be concerned about something like a tachycardia? Well, you want to be concerned about a tachycardia because when the heart rate is too high, it means that the heart muscle, the myocardium, its oxygen demand also increases. Because its oxygen demand increases, there's a possibility that the myocardium can suffer from myocardial ischemia. And if you get myocardial ischemia, you're going to present with this substernal pain in the chest called angina. If this continues and it gets quite severe, this can start to really damage the myocardium, and it can eventually lead to a myocardial infarction. So tachycardias can't be taken for granted. Physiologic tachycardias will return to normal. Pathologic tachycardias typically won't return to normal unless you treat them, typically. So let's take a look at a few of these tachycardias. Now these are all going to be tachycardias that are restricted to the ventricles. So there are two main types of ventricular tachycardias. So there are, ventricular arrhythmias, of which ventricular tachycardia is one of them. The other, of course, is ventricular fibrillation. Those are the two types of ventricular arrhythmias. We're going to talk about the ventricular tachycardias, and of these, there are two main types. So first, there are the monomorphic, then there are the polymorphic. Monomorphic and polymorphic ventricular tachycardias. Now, with ventricular tachycardias, the QRS complex is wide. It's wide. And your heart rates will usually range between 120 to 200 beats per minute, usually. Let's look at the monomorphic ventricular tachycardias first. So when you look at a monomorphic ventricular tachycardia on an EKG, you notice something very particular. Notice how all these complexes, these QRS complexes, look the same. If you go to the different leads, the various characteristics of each one of these is the same. They're also more or less roughly the same height, with some exceptions, of course, but as you look at these, they really start to look the same. In fact, they look monotonously the same. So that's a feature of a monomorphic tachycardia. And monomorphic tachycardias are usually a complication of myocardial scarring. That usually resulted from an acute myocardial infarction. So those are your monomorphic ventricular tachycardias. Now when it comes to your polymorphic ventricular tachycardias, now we're going to see that the QRS complexes have different shapes. And the reason they have different shapes is that they come from different areas in the ventricle. So they originate from various areas in the ventricle. And so here is an example of a polymorphic tachycardia. As we look here, we can see different sizes, different shapes. We get things that look like steps here and mountains here. These kind of all look the same, but the beginning part here doesn't. These kind of all really start to look different. There's a very different look to these as opposed to the monomorphic. So here, these are flat over here. They're pointy over here. They've got a little plateau, kind of buttes looking over here. Very different look. That's your polymorphic ventricular tachycardias. This is not associated with myocardial scarring. Not associated with myocardial scarring. Now, one particular cause of a polymorphic ventricular tachycardia is a relatively rare autosomal dominant genetic condition that's called Brugada Syndrome. So this is a rare autosomal dominant genetic condition. This is a mutation in the voltage-gated sodium channels. Of the myocardium. All right, so this is seen probably most commonly in people of Asian descent. And you will typically see things like this in the EKG of someone with Brugada syndrome. There's 3 types of Brugada syndrome. But the individuals, as you can see here, they may be asymptomatic. Others may present with symptoms like syncope, perhaps. In type 1, you have this ST segment elevation in V2. In type 2, instead of a elevation, you get this so-called saddle-shaped region here. And then type 3 also shows the saddle shape as well. So you either get the elevated ST segment or the saddle shape. In fact, a EKG from Brugada syndrome might look a little bit like a right bundle branch block. And you might see an RSR situation in the QRS complex in leads V1 through V3. That's something you might see as well. That's Brugada syndrome. Not terribly common. Now, regardless, all people with these polymorphic ventricular tachycardias, they're at risk of sudden cardiac death, and so you're going to treat them with an implantable cardioverter defibrillator. Now, there is a very specific and very dangerous type of polymorphic ventricular tachycardia that's called Torsade de Pointes. Torsade de Pointes literally means twisting of the points. And it simply means that the QRS complexes look like they're twisted about the isoelectric baseline. So if this line here, or this line here, or that line there, happen to be our isoelectric baselines, the QRS complexes just twist about them. This is seen essentially in individuals with an elongated QT interval. So anyone with an elongated QT interval is at a risk of developing Torsade de Pointes. And the things that can cause this, first of all, there are genetic conditions that can pre-expose you to this, most often ones that affect potassium channels. So, for example, there is so-called Romano-Ward syndrome. Romano-Ward syndrome is not associated with deafness. But there's a second one. It's called Long-Nielsen syndrome. That one is associated with deafness. You can also get this elongated QT interval from electrolyte. Electrolyte disturbances. So, for example, hypokalemia. That means your potassium's too low. That means your potassium is below 3 milliosmoles. Hypocalcemia can also. And so can hypomagnesemia. All three of these can predispose you to Torsade de Pointes. You want to look for these if someone has had some sort of GI disturbance, they've lost a lot of potassium because of either diarrhea or with vomiting. These can cause potassium loss and cause QT elongation. So that's something to be aware of. Then there are medications. Now with these, you want to remember A, B, C, D, E, just like that. So A would be your antiarrhythmics. Certain antiarrhythmics are very good at causing QT elongation. That would be your type 1s and your type 3s. B is going to be antibiotics. And the group here will be your macrolide antibiotics. Biggest culprit here is erythromycin. Tends to be dose dependent with erythromycin. C is going to be for antipsychotics. There are a couple of antipsychotics that predispose you to QT elongation. Ziprasidone, probably one of the bigger culprits. That goes by the trade name, I believe, of Geodon. And then olanzapine. Olanzapine's a weak one. And then haloperidol. That gets used a lot in psych wards to put people out. So if you work in a psych ward and a patient's been given that, you want to watch EKG. The other D is for antidepressants. Antidepressants. Biggest culprit here are the tricyclic antidepressants. And then E's are for antiemetics. And this would be your serotonin receptor agonists, and that would be ondansetron. This goes by the trade name of Zofran. This gets used a lot in hospitals for nausea. Its effect upon the QT interval tends to be dose dependent. There's other members of this group also, olanzapron, granisetron, so on and so forth. All of them have a dose dependent effect on the QT interval. All right, so let's get back to Clint. So with Clint, as we can see, Clint had a EKG that looked like this, and that is a Torsade de Pointes. And Clint is taking a tricyclic antidepressant. That is a cause of Torsade de Pointes, and amitriptyline is one of the biggest offenders when it comes to the cause of Torsade de Pointes. So Clint has Torsade de Pointes that has been drug-induced. How do we treat Torsade de Pointes? We treat it with intravenous magnesium sulfate. Intravenous magnesium sulfate treats Torsade de Pointes very effectively. And once Clint was treated, he was then able to be released from the hospital. Happy endings all around. And that, ladies and gentlemen, is what I wanted to tell you about ventricular tachycardias.